Welcome to our video on papulosquamous eruptions. Here's our overview slide. In this lecture, we'll be discussing 4 dermatologic conditions, including psoriasis, seborrheic dermatitis, lichen planus, and pityriasis rosea. In each case, we'll be discussing the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. So let's start with the definition of psoriasis. Psoriasis is an autoimmune inflammatory skin disease. The typical rash exhibits erythematous plaques with silver scaling. The most commonly affected regions are the extensor surfaces, such as the knees and elbows. Let's take a look at a picture of this. Here we see an image of the elbow in a patient who has psoriasis. Notice the way that these plaques have a red-pink base overlaid by a silvery white scale. There even appears to be a small area on the arm where the plaque was scraped off and bleeding occurred. Make sure that this is a rash that you can immediately recognize when given an image. As with many dermatologic conditions, the etiology of psoriasis is not well defined. Here we see a list of risk factors for psoriasis. They include a family history of the disease, obesity, smoking, and alcohol use. In addition to predisposing factors, there are various potential triggers of psoriasis. Skin trauma is one cause worth mentioning. Even just minor friction, such as a plumber who is working on his knees to fix a toilet, can give psoriatic lesions in a process known as the Koebner phenomenon. A large number of medications have been associated with psoriasis, including antimalarials such as hydroxychloroquine and beta blockers such as metoprolol. Infection is another recognized trigger for psoriasis, particularly HIV and streptococcal pharyngitis. In HIV patients, the disease process often comes on very suddenly and is relatively severe. Finally, patients that are abruptly withdrawn from oral steroids may also develop psoriasis. The clinical presentation is fairly distinct. As shown previously, patients will have erythematous plaques that are often overlaid by silver scales. Were you to remove these scales, the area would bleed. And this is known as the Auspitz sign and is classically associated with psoriasis. Again, the extensor surfaces tend to be most affected, and the rash will be exacerbated by trauma. Let's break up this lecture with a question. In a patient with skin lesions consistent with psoriasis, the following image could help to diagnose what concurrent condition. Okay, so this question requires a knowledge of disease processes that can be seen in addition to the skin manifestations of psoriasis. The nails and toes of this patient have been severely altered. In particular, onycholysis can be noted over multiple toes. Onycholysis is when the nail starts to detach from the nail bed. In a patient with psoriasis, this is classic for psoriatic arthritis, which is the answer to our question here. For a much more detailed review of this condition, take a look at our video on seronegative spondyloarthropathies. The diagnosis of psoriasis can be made clinically based on the characteristic history and physical exam findings just described. Were there a degree of uncertainty, a skin biopsy might be done. The histology of a patient with psoriasis would show epidermal hyperplasia, parakeratosis, and Monroe microabscesses. Let's take a look at how this might appear under the microscope. Here we see a pathology slide of a patient with psoriasis. First, notice the marked epidermal hyperplasia. Additionally, we see that many nuclei have been retained within the bright pink stratum corneum layer on top of the image, which is known as parakeratosis. In the image on the right, we can see neutrophils migrating to the corneal layer. As these infiltrate the stratum corneum, they may come together to form Monroe microabscesses. As you can tell, much of this disease process has to do with the stratum corneum layer. To help remember the association of psoriasis with the stratum corneum, consider the phrase corn on the cobner. This sounds like corn on the cob. Psoriasis classically affects the stratum corneum and often displays the Koebner phenomenon, where the rash gets worse with trauma to the area. While the Koebner phenomenon is not unique to psoriasis, this may serve as a helpful memory hook as you look to remember the layer of the skin that we see affected when looking under the microscope in a patient with psoriasis. The management of psoriasis can get complicated, and this is by no means an exhaustive list. Here, we've simplified the therapy into 3 groups of the higher yield treatment modalities: topical medications, UV light, and immunomodulators. As a general principle, a combination of therapies is usually the best choice. Topical high-potency steroids such as beclomethasone and emollients or moisturizers are a great first option for treating this rash. Recall that we shouldn't give oral steroids to these patients because they can give a severe flare-up of the rash when discontinued. Topical vitamin D derivatives, such as calcipotriene and calcitriol, can also be effective. Phototherapy with UV light has been used with some success in moderate to severe cases. The most severe cases of the disease may necessitate immunomodulators. These include things like etanercept, which is a TNF-alpha inhibitor, and methotrexate. All right, let's try another question to help reinforce this important disease process. A 29-year-old female presents to the family medicine clinic with an uncomfortable scaly rash over both elbows that has increased in size since she started Army boot camp. When the scales are scraped off, mild bleeding is seen. The patient's medications include topical hydrocortisone for eczema, esmolol, and levothyroxine, which medication, if discontinued, may improve her symptoms. All right, from the question, we can deduce that psoriasis is a highly plausible diagnosis for this patient. Participation in Army boot camp, which involves the friction of crawling on one's hands and knees, seems to have exacerbated the rash. Additionally, there was bleeding when the scale was removed. This is the Auspitz sign, which is highly suggestive of psoriasis. The question wants to know which of her medications, if discontinued, may improve her symptoms. In other words, which of her medications has the potential to worsen the rash of psoriasis? The correct answer here is esmolol, since beta blockers are a known precipitator of psoriasis. Topical hydrocortisone is incorrect, as this is a corticosteroid medication that, if withdrawn abruptly, may worsen her symptoms. Instead, this is a helpful medication in treating psoriasis and could be applied over the affected area. Finally, levothyroxine is also incorrect, as this medication is not known to aggravate psoriasis. Interestingly, there does appear to be a link between patients with psoriasis having concomitant thyroid disease. We'll next discuss seborrheic dermatitis. Here's our overview slide again, and we'll begin by discussing the definition of seborrheic dermatitis. Seborrheic dermatitis is a flaky, oily, and erythematous rash. It tends to affect regions with a high quantity of sebaceous glands, such as the nasolabial region, the head, ear, and the intertriginous areas. Seborrheic dermatitis is recognized as a chronic inflammatory condition. Because we do not completely understand its cause, it's considered idiopathic. This dermatologic disease most commonly presents in infants, particularly in the first year of life or in middle-aged adults. There may be an association with the fungal infection Malassezia furfur, which becomes important as we consider treatment. Individuals with oily or greasy skin are more prone to developing this. Another risk factor is the presence of a CNS disorder, like Parkinson's disease. Finally, HIV is something to consider as well in these patients. The clinical presentation varies slightly based on the age group affected. We'll start by discussing infants before touching on middle-aged adults. Infants can either get a cradle cap appearance on the head, which we'll highlight on the next slide, or a diaper rash accompanied by scales and blisters. Here we can see an infant with the so-called cradle cap covering the entire scalp. Notice that some areas appear flakier and more easily removable than others. In middle-aged adults, this more commonly presents as dandruff, greasy scales with red plaques over the head and face, or blepharitis. Blepharitis is when the margin of the eyelid gets inflamed. Patients may experience a gritty sensation within the eye, excessive tearing, and crusting eyelashes in the morning. Here we see a person affected by seborrheic dermatitis. Notice its red, flaky appearance near the nose and lips. Images of this rash often show the head or face. Here we see an image of a patient with blepharitis. In this condition, the meibomian glands, which are oil glands at the margins of the eyelid, become blocked, causing a backup of the secretions and significant swelling. This helps to explain the discomfort of the eyelids that patients experience. The conjunctiva often become inflamed in these patients as well. And these findings tend to occur bilaterally. Seborrheic dermatitis is a clinical diagnosis based on the characteristic history and physical exam just described. In infants with cradle cap, emollients and non-medicated shampoos are the first-line treatments. Essentially, we want to moisturize and clean the area. A soft brush can also be used to scrape away the flakes after the area has been cleaned. As additional treatments, topical antifungals like ketoconazole or low-dose steroid creams such as hydroxycortisone can also be used. If the intertriginous region of an infant is primarily affected, we can give topical antifungals, particularly since there is often a superimposed candida infection. For the seborrheic dermatitis infection of middle-aged adults, the best treatment is antifungal medications. Topical ketoconazole can be applied to the lesions, and antifungal shampoos can be used in cases where the scalp is affected. Selenium sulfide is another medication with antifungal properties that is also effective. Warm compresses and ocular massages are used to treat blepharitis. All right, time for another question. A 32-year-old male wakes up with a new rash that is diagnosed as severe seborrheic dermatitis. The inside of his mouth has had a diffuse white color to it for the past month. In addition to treating his dermatologic condition, what should he be screened for? All right, this is a relatively straightforward question, but an important one nonetheless. This patient has an abrupt onset of severe seborrheic dermatitis. Also, his mouth has had a diffuse white color to it for the past month, which sounds a lot like a Candida infection. Taking these two together, this patient needs to be screened for HIV. HIV is an important risk factor that should be considered in someone with new onset seborrheic dermatitis, particularly if they have another finding concerning for HIV in the question stem, such as the probable Candida infection described here. The prevalence of seborrheic dermatitis in patients with HIV is fairly high. Recall that HIV is also a risk factor associated with the severe and sudden onset of psoriasis. All right, let's move on to lichen planus. Let's begin by discussing the definition of lichen planus. Lichen planus is a chronic inflammatory disease. It's characterized by lesions that primarily affect the skin, genitalia, and mucous membranes, most notably the mouth. When it comes to the pathophysiology of lichen planus, it's thought that oral lichen planus involves a CD8-positive T-cell response that can cause apoptosis of the oral epithelial cells. The cause of the other manifestations, such as lichen planus affecting the skin or genitalia, is not well established. Lichen planus often affects middle-aged adults. One very high-yield risk factor to store in the back of your mind is that lichen planus has an association with hepatitis C. To help you remember this, think of the letters PC, as in the computer. So it's lichen P with hep C. Much like psoriasis, certain medications can lead to lichen planus. A few of these include beta blockers, thiazide diuretics, and anti-malarial drugs. The clinical presentation of lichen planus is commonly remembered as the 6 Ps, which are used to describe the characteristics of the rash. The rash is planar, pruritic, polygonal, purple, and can have papules and plaques. The most commonly affected areas are the wrists, shins, genitals, and the oral mucosa. One highly recognizable feature is the presence of lacy thin white lines within the affected areas, which are referred to as Wickham striae. Finally, this disease can be exacerbated by trauma in the same way that psoriasis can. Here we see the shins of a patient affected by lichen planus. This lesion does a fairly good job of highlighting the characteristics of this rash. It's purple, a bit papular or raised, planar, since the raised lesion is flat, and it's likely pruritic. The other 2 Ps would be polygonal and papular, which aren't shown here. Here we can see the mouth of a patient affected by lichen planus. We can appreciate the presence of Wickham striae running up and down the oral mucosa. Oral lichen planus can be very uncomfortable, especially when the patient is eating or talking for a long amount of time. The diagnosis can usually be made with history and physical exam alone. Were you to perform a biopsy for confirmation, it may show a lymphocytic infiltrate and hyperkeratosis. Let's take a look at this on a pathology slide. Here we see the histology of a patient with lichen planus. First, notice the extensive lymphocytic infiltrate that's present throughout. Much of this will occur in the more superficial dermis near the dermal-epidermal junction. We can also appreciate hyperkeratosis in this image where the superficial skin layer has thickened. As far as management goes, this is a chronic, relapsing condition that tends to resolve within 2 years. Mild cases are treated with topical steroids, and more severe instances may require systemic steroids or phototherapy. We should screen these patients for hepatitis C if any risk factors for this, such as IV drug use, are present. Because many cases of this are drug-induced, we should also seek to discontinue any offending medications. All right, let's try another question. A 39-year-old male with hypertension presents to the emergency department for an odd rash. His hypertension is well controlled with hydrochlorothiazide. He has no history of IV drug use. His vital signs are stable, and he is in no acute distress. After obtaining a further history and performing a physical exam, the diagnosis remains unclear. A biopsy is obtained and the patient is diagnosed with lichen planus. What is the best next step in the long-term management of this patient? All right, this is a classic step 2 question, as they love to ask for the next best step in management. The key here is that we're talking about the long-term management of a patient diagnosed with lichen planus. It may be tempting to answer something like treat with topical steroids. This is a good thought, but doesn't address the reason the patient developed lichen planus in the first place. Recall that the 2 major risk factors for this are hepatitis C and medications. It's unlikely that this is related to hepatitis C, as the patient has no history of IV drug use. This takes an answer such as obtain a liver enzyme panel off the table. Medications, however, could be at play here since the patient is taking hydrochlorothiazide. As such, the correct answer would be discontinue hydrochlorothiazide. This is the most likely culprit, and many other drugs could be used as alternatives to control his hypertension. All right, we'll conclude this lecture by discussing pityriasis rosea. So we'll begin by discussing the definition of pityriasis rosea. Pityriasis rosea is a two-stage dermatologic condition. The first stage is characterized by a small erythematous patch with a scale. This will then progress to an eruption of oval-shaped erythematous lesions along the lines of tension. We don't know exactly what causes this disease process, but it might be a reactivation of human herpes virus 7. Part of what makes us think this is that patients may get a viral prodrome before the rash appears. The age groups that tend to be most affected are early adolescence and young adulthood. There is a slightly greater prevalence of this disease in females when compared to males. As you can tell by these limited risk factors, we don't have a great grasp on what predisposes a patient to this. The clinical presentation of pityriasis rosea may begin with a viral prodrome. By this, we mean that they may have nonspecific symptoms, such as a fever, nausea, muscle aches, and a headache. Then the patient will get a characteristic set of rashes. First comes the herald patch, followed by a secondary eruption of oval-shaped lesions in a Christmas tree pattern. Let's take a look at these two rashes. Here we see the characteristic herald patch that serves as the first manifestation of pityriasis rosea. Notice the circular erythematous patch right here, which often has this salmon-colored tinge to it. It will tend to present somewhere over the trunk of the patient and often takes on a cigarette paper-like scale with time. At this stage, it would be easy to mistake this rash for ringworm. In this image, we can see the secondary eruption that occurs in patients with pityriasis rosea days to weeks after the herald patch. You should appreciate the Christmas tree-like appearance of these erythematous lesions. The lesions tend to occur over the skin lines, which are the areas of greatest tension along the back. It often involves the trunk or upper arms, but may present on the face in children, and the rash tends to be very itchy and uncomfortable. The diagnosis is made clinically. In cases where infection with tinea cannot be adequately ruled out based on the history and physical exam, a KOH test can be performed to rule this out, since the herald patch can appear very similar to ringworm as you just saw. All right, let's try a quick question. How can we differentiate the rash of secondary syphilis from the secondary rash of pityriasis rosea? Here, we've created a very simple table to answer this question. Each of these disease processes will have a unique preceding lesion. Pityriasis rosea shows a herald patch, usually on the torso as described earlier. The primary presenting lesion in patients with syphilis is a chancre, which is a painless erythematous genital ulcer. While both rashes are papulosquamous in appearance, the rash of secondary syphilis will often involve the palms and soles, which is a key distinction. Another distinguishing factor for syphilis might be the mention of risky sexual practices or a prior history of sexually transmitted diseases. All right, now let's move on to management. Pityriasis rosea tends to self-resolve within a couple of months. As the itching can become especially bothersome, antihistamines such as diphenhydramine are often given for relief. All right, we'll conclude this lecture with a board-style question. A 44-year-old male presents to the clinic because he has developed itchy purple spots on his left wrist over the past month. He does not wear anything on his wrist and has no history of recent outdoor activity or travel. He has one lifetime sexual partner and no history of IV drug use. He underwent a blood transfusion as a child in 1984. He takes no medications. Blood pressure is 128 over 81 millimeters of mercury. Pulse is 77 beats per minute. Temperature is 37.3 degrees Celsius. Respiratory rate is 18 breaths per minute. BMI is 23. Physical examination shows flat, purple lesions of varying sizes along the anterior aspect of the left wrist. There are a series of white lines coursing through the lesions. Liver function studies show a total bilirubin of 0.9, alkaline phosphatase of 80, alanine aminotransferase, or ALT, of 122, and aspartate aminotransferase, or AST, of 109. Which of the following should be evaluated for in this patient? A, HIV, B, alcohol use disorder, C, hepatitis C, or D, non-alcoholic fatty liver disease? All right, to be able to answer this question, we first need to diagnose this patient's rash. The rash is described as itchy purple spots on the left wrist. The patient does not wear anything on this wrist, such as a wristwatch or bracelet, making contact dermatitis an unlikely cause. Additionally, there is no history of recent outdoor activity or travel that would suggest something like a tick bite. Some of the patient's history helps to exclude other conditions, but it's the physical exam that gives this one away. It shows flat purple lesions of varying sizes with a series of white lines coursing through them. These are the telltale descriptors of lichen planus, particularly given the mention of these lacy white lines within the lesions that are known as Wickham striae. The question stem then is asking which diagnosis we should evaluate for in this patient with lichen planus. Recall that there are two major risk factors for lichen planus: medications and hepatitis C. This patient takes no medications, making it worthwhile to obtain liver function studies to see if hepatitis C could be at play. Note that the ALT and AST are elevated, indicating some sort of pathology within the liver. Additionally, the patient underwent a blood transfusion in 1984. This is an important piece of information because hepatitis C was not screened for in blood products until the early 1990s. Given this, answer choice C, hepatitis C, should be looked for in this patient, and this is the correct answer. Answer choice A is incorrect, as HIV does not appear to have a clear association with lichen planus. Additionally, this patient only has one lifetime sexual partner and has no history of IV drug use. Answer choice B is incorrect, as alcohol use disorder isn't a risk factor for lichen planus. Also, we would expect patients with a liver affected by alcohol to have an AST value that is greater than the ALT value, and the opposite is true here. Finally, answer choice D is incorrect. It's unlikely that a patient with a BMI of 23 would have non-alcoholic fatty liver disease, given its association with metabolic syndrome and elevated BMIs. Additionally, this is not a traditional risk factor for lichen planus. So again, the correct answer is C, hepatitis C. And that concludes this section.